and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, an update on cervical cancer screening and prevention in Alabama. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, expiring on January 31st, 2017, and 2 years for social workers, expiring on January 31st, 2018. I'm Nancy Wright, Director of the Division of Cancer Prevention and Control with the Alabama Department of Public Health, and I would like to welcome our faculty presenters today. Dr. Stephen Varner, Associate Professor of Obstetrics and Gynecology at the University of South Alabama, and Dr. Michelle Kahn, Assistant Professor of Obstetrics and Gynecology at the University of Alabama at Birmingham. Welcome. And now we will begin the program with Dr. Varner's presentation.
Thank you. Glad all of you could join us today. We're going to talk about a number of aspects of screening for cervical cancer. I want to start off by just looking at the scope of the problem and the missed opportunities that we have in order to prevent cervical cancer. So let's start off with the fact that I do not have any conflicts of interest and our objectives today. First of all, you will understand the scope of the problem of cervical cancer in both the United States and in Alabama. Also understand ways of decreasing missed opportunities of screening women for cervical cancer, and also you will understand the importance of offering or referring young women for HPV vaccines. So cervical cancer screening, obviously, as you all know, is a tremendous success story. Even back as far as 1987, if you look at it from the start of the pap smear until that time, cervical cancer rates decreased 75%. And we're still seeing decreases today, but we'll also see how in a preventable disease, a truly preventable cancer disease, that we still have way too many people not only getting cervical cancer but dying from cervical cancer today. Let's look at a few trends. From 2002 to 2011 in the U.S., you can see that the incidence rates of cervical cancer have decreased. Not tremendous amounts, but they are significant. So depending on what race, ethnicity, we are seeing a decrease in cervical cancer anywhere from about 1% to around 3% for the Asian Pacific Islander women. Mortality trends also are following in about the same percentage, so somewhere around 1% for women in general, and as high as 3% for Asian Pacific Islanders, and for African Americans, it's a little over 2%. If you want to look at the latest data that we have in 2012, the incidence of cervical cancer, you can see in the U.S. That there were about 12,000 people who were diagnosed with cervical cancer in 2012. In Alabama, we had 233 or thereabouts. Mortality in the U.S. was 4,000 people, and in Alabama about 78. Now, again, this is, as we all know, a preventable disease. So these are people who are getting cancer, having all of the treatments, the morbidity that go along with that, and who are dying unnecessarily. If you look at the rates in the U.S., it's 7.4 per 100,000 women, and in Alabama we are about 20% higher than that, so 9.4%. Mortality in the U.S. is 2.3 per 100,000, and again in Alabama we're about 20% higher than that. Cervical cancer incidence in the state of Alabama, we are the third highest state in the union. The cervical cancer mortality rate, we're a little better, but still we are seventh highest in the United States. Both things that we obviously need to work on. If you look at cervical cancer again in 2012 broken up by ethnicity, you can see that in the U.S. it's about 7.4. Among white people in the U.S., white women in the U.S., it's 7.1. African Americans are 9.0. Hispanics are 9.5, and Asians 6.1. In Alabama, we don't have data on all of those ethnicities. Interesting, though, you can see that the incidence among white women is actually higher than the incidence among African Americans. However, look at the mortality rates. The mortality rate for white women in Alabama is 2.5, and the mortality rate for blacks or African Americans are 4.5. So certainly an area that we need to work on. If you look at insurance data, you can see that 7 out of 10 women who have not been screened in the last 5 years have had a regular doctor visit and have had health insurance. So 70% of women who haven't been screened do have health insurance and they have seen a physician. More than half of all new cervical cancers occur in women who have either never been screened or who have not been screened in the past 5 years prior to that diagnosis. In a study in 2009, Decker found that there were so many missed opportunities for women who could have been screened. In the 5 years prior to diagnosis of cervical cancer, there were almost 18 opportunities for these women to have been screened. And in 2014, only 36.8% of adolescent females in Alabama had greater than or equal to 3 HPV vaccine doses. And cervical cancer screening is provided more consistently in urban areas rather than rural areas, which of course helps to explain a little bit about what kind of problems we are facing in Alabama. In the United States, only 23% of women 18 to 26 years of age had at least one HPV vaccine in a study by Williams in 2013. If you look at this graph, you see that this is the estimated HPV vaccination coverage among adolescents aged 13 to 15 in Alabama. And you can see that we started off increasing, even though it was started off lower, we started off with a pretty good increase, and then from 09 to 12, we really went backwards during that time. We have made some progress since then, but we have a long ways to go in giving people a vaccine that can prevent cervical cancer as well as other types of cancers. In a study in 2005, they looked at insurance claims and women who did not have a pap smear in the last 3 years. 87% had at least one doctor's visit, and of those women who did not have a pap smear in the 3 years during that time, the average number of health insurance claims for those women was 25. So there's lots of opportunity for us to get people screened. 44% of those claims were with primary care providers. Unfortunately, many women with late-stage cancer had a pap smear and with abnormal results and were lost to follow-up. So getting people to be screened, not missing those opportunities, and then making sure we don't lose those people to follow-up. Extremely important. All right, so let's look at our opportunities that we really need to take advantage of. Make sure that you are either screening or referring all women in your practice according to published guidelines. You need to know the screening guidelines and be careful not to waste limited resources. By screening more frequently, it has not been shown to be more helpful or decrease morbidity and mortality. But by all means, screen them when it is appropriate. We need to educate women regarding the importance of screening, address barriers and fears that they may have. We need to design a system within your office that will ensure proper follow-up and limits the loss to follow-up patients. Also, make sure that you strongly recommend and educate preteens and teens regarding the importance of the HPV vaccines. Administer them or refer them for the vaccine. Thank you. I'm going to turn it over to Dr. Khan now, as she's going to talk about screening in Alabama.
Thank you, Dr. Varner, and thank you all for being here today. What I'm going to go over are the current screening guidelines, and they have changed multiple times over the last decade, so sometimes a review is good for everyone. And I want to help you understand also in this talk what the rationale is for some of these guidelines, since there are multiple options for some of the age groups, and deciding which option to use is sometimes difficult. My disclosure is that I have received reimbursement from a company for travel to an investigator's meeting. I'm no longer involved with that study. And we'll be talking about the guidelines that are current for cervical cancer screening, which include the U.S. Preventive Service Task Force guidelines and the combined American Cancer Society, American Society for Colposcopy and Cervical Pathology, and American Society for Clinical Pathology joint guidelines. Those two sets of guidelines came out around the same time in 2011, and ACOG guidelines as well, which reiterate the U.S. Preventive Services as well as the combined screening guidelines. And what I want you to understand with this talk is the performance of the screening tests, including the PAP alone versus the PAP plus HPV co-testing, to get a better understanding of why co-testing came onto the horizon in the latest screening guidelines. So these are the documents for those three guidelines, and I'll be referencing the U.S. Preventive Services Task Force and the combined guidelines during this talk. Hopefully you have a handout that you can look at this, since it's a little small on the screen. This is the summary table of the screening guidelines from the U.S. Preventive Services Task Force. And this is the summary table from the joint ACS, ASCCP, and ASCP guidelines. And we'll be looking at each of them. They're essentially very similar. There's very minor differences between the two. And we'll talk about each of these age groups and what's recommended for those age groups. So let's start off with women less than 21 years old. And I'm looking on my screen here since it's a little bit small to read. So women less than 21 should not undergo cervical cancer screening. In the past, we used to say start at age 18, start within 3 days of last intercourse. We've come to understand that patients under age 21 are at very low risk of cervical cancer and do not need to be screened. And the little box over in the right side says HPV testing should not be used for screening or management in this age group. Now, why is this the guideline? Here's the joint screening guidelines, and it says similarly, do not screen and do not screen with HPV testing. One rationale here under timing of screening is that screening women younger than age 21, regardless of sexual history, leads to more harms than benefits. So the U.S. Preventive Services Task Force really focuses on harms versus benefits of screening, and they look at the potential harms for each age group and the potential benefits of screening, and we'll talk about this through each of the categories. And they determined that under 21 years old, the harms outweigh the benefits of screening in this group, so it's not recommended. Let's talk for a minute about why that is. Well, first of all, HPV is very common in this age group. The average age of first intercourse is in the mid-teens, and that's when teens start to acquire HPV. With multiple partners, they get exposed to different HPV types. HPV being very common, the rate of cervical cancer is very low in this group. In adolescents 15 to 19 years old, the rate of cervical cancer is 0.1 per 100,000. And in women aged 20 to 24, the rates are 1.3 per 100,000. By comparison, the rate of cervical cancer in all women in the U.S. is 7.7 per 100,000. And then if you look at the older age groups, women aged 40 to 44, the rate is 15.8 per 100,000. So that's a big difference from the rates that I showed you in the adolescents and the young women. I also want you to keep in mind that HPV is very common. You can see in this graph an HPV prevalence by age. And on the bottom you can see at less than 20 years old and 20 to 24 years old, the HPV prevalence is very high, almost 25%. And in some studies where teens might have multiple partners, it can be as high as 50%. So we know that HPV causes changes in the cervical cells, and screening will detect those changes. So if we screen someone who's under 21, then you're very likely to find an abnormality, and that's going to lead to subsequent procedures like colposcopy, biopsies, and possibly treatment. So one thing we've come to learn is that HPV is very common, it's very transient in this population, and it's something that needs to be monitored but not necessarily acted upon until it becomes more of a persistent issue. When we look at the cancer rates by age group, you can see that the rates in under 20 years old is 0.1% of all the new cases of cancer, so a very small proportion. When we look at mortality, you can see the mortality rate is 0% in under 20 years old. So it's very important to keep these things in mind. When you're doing cancer screening in general, you want to screen the people at highest risk, and this group is just not at high risk for cervical cancer. So women under age 21 should not be getting pap smears who are in the general population. So let's go back to our joint screening guidelines table, and let's talk now about the women aged 21 to 29 years old. What's recommended for this age group is cytology or pap smear alone every 3 years. In that little box on the right side, it reiterates that HPV testing should not be used for screening in this age group. And the reason for that is similar to what we had looked at before with the HPV rates being very high in the early 20s. This is the U.S. Preventive Services document, and it says similarly that for women aged 21 to 29, this one groups at 21 to 65, screening with cytology every 3 years is one of the options. And on the right side says don't screen with HPV testing for women younger than age 30. Now, in terms of the harms and benefits, which the U.S. Preventive Services always looks at, what they wrote in this document is that screening women aged 21 to 65 every 3 years with cytology provides a reasonable balance between benefits and harms. and screening more often than every 3 years with cytology confers little additional benefit with large increases in harms. And so this is where the change from previous guidelines of a PAP every 2 years or a PAP every year came, because they found that screening more often could actually increase the harm rather than the benefit. And this again is showing that high HPV prevalence in the women under age 30, just to reiterate the point that they shouldn't be having HPV testing and that these women should undergo the cytology every 3 years. So now we're going to move on to women aged 30 and above, and this age group is 30 to 65, and there's 2 options for screening in this age group. You can either do cytology every 3 years, just like we were talking about for the women aged 21 to 29, or you have another option in this group, which is to add an HPV test to the pap smear. So you have HPV and cytology, which is known as co-testing. And if you do that combination, what's recommended is every 5-year testing. And in these joint screening guidelines, this was called the preferred method, and I'll show you some of the data which was the reason why it was called preferred, and the cytology alone every 3 years was called acceptable. So in reality, you can do either of these methods. These 3 organizations said that co-testing is preferred over cytology alone. And at that time, screening by HPV testing alone was not recommended for most clinical settings. There has since been a guidance that came out that I'll mention later in this talk about screening for HPV by itself. When we look at U.S. Preventive Services Task Force, they give you those 2 options again, either cytology every 3 years or co-testing every 5 years. And they don't give a preference of one over the other. They say you can use either. And then they do note in the bottom under balance of benefits and harms that the benefits of screening with co-testing every 5 years outweighs the harms. So this again is a small graph, and you might need to look at your handout to see it, but this shows some of the data behind those guidelines and why co-testing was incorporated. So if you look at the graph on the left-hand side, on your y-axis you have years since enrollment. On the x-axis you have years since enrollment. On the y you have cumulative incidence of CIN3 or worse. So CIN3 is a precancerous lesion. Worse would be cancer. So this is looking at what the 5-year risk is of cervical precancer or cancer. And each of those lines represents a screening group, someone who is screened with a pap smear alone or someone who is screened with HPV alone, and what the result was. It shows what their risk is over 5 years. So that top red line is someone who's screened positive with a HPV test alone. You can see that their risk over 5 years of having cervical precancer or cancer was 7.6%. Someone who screened positive with a pap smear alone had a risk of 4.7% over 5 years. So those who had a positive HPV result had a higher risk of precancer over 5 years than those who had an abnormal pap smear. When we look at the negative results, the blue dotted line, which is the second line up from the bottom, is women who tested negative with a pap smear. And what you can see is that 0.36% of them had cervical precancer or cancer over 5 years. And that last line is women who tested negative for HPV. This is at baseline at year 0. Over 5 years, 0.17% had CIN3 or worse over the 5-year follow-up. And if you look at the 3-year follow-up, you can see that the risk in the women who had a negative pap smear is equivalent to 0.17% which is very similar to the women who had a negative HPV test. Now we look on the right-hand side of the graph, and here we're integrating the HPV with the PAP result. And what you can see is that over 5 years, a combination of a negative pap smear and a negative HPV test conferred a 5-year risk of cervical precancer or cancer of 0.16%. So this is equivalent to that 0.17% that you have with a negative pap smear at 3 years. And this is the reason why the interval of 5 years was chosen for a negative co-test. And the interval of 3 years was chosen for a negative pap smear. They're equivalent risks. We're trying to treat women similarly according to their risk of cancer. And then when you look further out in women who've been screened twice, so if they came in 3 years later, had another pap smear, you can see all of these risks go down even further. So having multiple negative screening tests really lowers your risk of disease over time. And this is why the pap smear has worked so well over the last several decades, is because we repeat it. You know, it doesn't have the highest sensitivity, but when it's negative, that's a good thing. You're at a lower risk category. It's negative again, you're at even lower risk, etc. So just to reiterate that interval for screening, every 3 years of pap smear was equivalent in risk to every 5 years of a pap and HPV test, also known as a co-test. And so that's why those intervals were chosen. So let's go back to our table. And that was for women aged 30 to 65. Now the question comes up of, how long do you screen someone? When do you stop screening? When is it safe to stop screening? And for every cancer, there's a slightly different answer for this. For cervix, we have to keep in mind what the natural history of the disease is. And women get infected with HPV in their teens and early 20s. It takes about 10 years for a cervical precancer to develop, and then another decade or two for cancer to develop. So about 20 to 30 years for cancer to develop, given an HPV infection. So what has been determined is that beyond age 65, the benefits of screening may not outweigh the risks in this age group. And so no screening is recommended as long as women have had adequate negative prior screening. We're going to talk about what that means. There's a caveat here. If women have had a history of cervical precancer or cancer, then they should continue screening for at least 20 years, regardless of if this takes us above age 65. And the U.S. Preventive Services Task Force says the same thing, which is do not screen women age 65, older than age 65, who've had adequate negative screening. So what defines adequate negative prior screening? If you have someone who comes in who's 66 and you're deciding whether or not to do a pap smear on her, you need to look back at her pap history. In the last 10 years, she should have had either 3 consecutive negative pap smears or 2 consecutive negative co-tests, with the most recent being in the last 5 years. And if she meets that criteria and doesn't have a history of cervical precancer or cancer, then you would not need to screen her further. This table shows some of the data underlying this recommendation. And what they looked at was the outcome of CIN3+ and the outcome of cancer if you were to screen women 65 or older. And they found that continuing screening to age 90 prevented only 1.6 cancer cases and 0.5 cancer deaths per 1,000 women. And these were both modeling studies because there's not a whole lot of data in 90-year-olds. They also looked at colposcopies and how many colposcopies you would have to do in this older age group. They found that continuing screening to 90 years old results in an additional 127 colposcopies per 1,000 women. And the possible harms of colposcopy include pain, anxiety, discomfort with the exam, biopsies, having to proceed on with excisional procedures, etc. They determined that those harms outweigh the benefits of screening at greater than 65 years old. I want to mention briefly guidance that came out last year, and this was the use of HPV as a primary screening test for cervical cancer. And this came out after the latest guidelines that we have been discussing. So it wasn't part of a consensus conference like those were, but it was a group of experts that reviewed the data from a trial on HPV testing and determined that HPV testing could be used as a primary screening method. If we look back at the graphs that we were looking at earlier, on the left side we looked at what a HPV negative result means over time, and you saw that at 3 years the risk with a negative HPV test was 0.063% for cervical precancer or cancer. Over 5 years the risk was 0.17%, which was equivalent to the risk over 3 years with a negative pap smear. And so an HPV test, if negative, provides a lot of reassurance that you will not have cervical precancer or cancer over the next 3 to 5 years. And so what was recommended in terms of using HPV as a primary screening test was to send the HPV test. If it's negative, that's reassuring. They go back to routine screening. And routine screening was recommended to be every 3 years. If the HPV test is positive, then you want to consider doing a genotype. If you have 16 and 18 genotyping, if either of those are positive, you would send the woman directly to colposcopy. If those are negative and you have other high-risk HPV positive, and we haven't really talked today about the different types of HPV, but I'll mention just briefly that 16 and 18 cause the majority of cancers, about 70% of cancers, and have the highest rates of persistence and lead to more disease than some of the other types. And so we separate those out in a lot of the guidelines, and anyone with those types go directly to colposcopy. In women with the other types, then at that time cytology is used as a secondary triage method. And if they have an abnormal cytology, then they would go to colposcopy. A lot of places have not incorporated this screening algorithm yet because there's different issues to work out in terms of insurance coverage and follow-up and just protocols in general. But this is something that's on the horizon and will be discussed in the next set of consensus guidelines. So going back to our table, our next group are women who've had a hysterectomy. And what's recommended is no screening in this group. Why is that? Well, they don't have a cervix, and so they are unlikely to get cervical cancer. And this only applies to women without a cervix. So if they've had a supracervical hysterectomy and still have a cervix, they would need to still undergo cervical cancer screening. It also applies to women who've never had a history of CIN2 or worse. Anyone with a history of CIN2 or worse needs to be screened for at least 20 years after their treatment, regardless of whether or not they have a cervix. U.S. Preventive Services Task Force says similarly, do not screen women after hysterectomy with removal of the cervix with no history of high-grade precancer or cervical cancer. And they note that the harms of screening after hysterectomy outweigh the benefits. So just to understand a little bit better why we don't screen after hysterectomy, what we'd be doing if we were to do a pap smear after a hysterectomy is really screening the vagina for cancer because there's no cervix left. However, vaginal cancer is much less common than cervical cancer. From 2004 to 2008, there was an estimated 500 HPV-associated vaginal cancers per year. Compare that to about 12,000 of cervical cancers. When you look at the incidence rates of vaginal cancer, they range from 0.4 to 0.6 per 100,000 women, as compared with cervix, which is 7.7 per 100,000. So a lot lower incidence than cervical cancer. Another reason is that abnormal vaginal smears can be very common, but cancer is very rare. So this was a study from New England Journal of Medicine in 1996, and they looked at vaginal cytology samples after hysterectomy, almost 10,000 of them. And of those vaginal cytologies, 1.1% were abnormal. However, they followed those women, did biopsies, they found no vaginal precancer or cancer. So in 10,000 women screened by cytology, they found no precancer or cancer. So the disease that we're screening for is so rare that it makes the screening not really recommended to be done in this group. There's no good guidance in terms of what to do after an abnormal vaginal cytology, and this is a paper that myself and Dr. Ha at UAB, as well as other experts in the field, put together after looking through the literature on vaginal cancer screening and seeing what the tests have shown, what the studies have shown. There wasn't enough data to produce any evidence-based recommendations, but we felt that there needed to be a guidance out there in terms of how to manage women who've had pap smear or vaginal cytology after hysterectomy, and how to manage them to get them out of that cycle of having repeated pap smears, especially for the women who shouldn't have had one in the first place. So that'll be coming out in the next month or two. These are the references for my presentation, and we'll be happy to take any questions on screening at the end of the webinar. At this time, we'll take a break, and then we'll move on to management.
Hello, and welcome back from the break. We do have a few questions from the audience that we wanted to give them a chance to ask before we start the next segment. So if we could have questions from the audience.
Okay. I was just curious, with all the changes in pap smears, how important is it for women to have that annual pelvic exam?
That's a great question. Did you want me to address that? Okay. So the pap smear guidelines have extended the intervals, and so now women are getting them every 3 to 5 years. And this question comes up a lot. What the data is that having a pelvic exam hasn't been shown to increase the detection of ovarian cancer and other types of cancer. However, what we do know is that when women come in for their annual visit, they often do have complaints like menopausal symptoms, vaginal dryness, maybe discharge or itching or other things that need to be addressed. So we still recommend that women come in once a year. Now, what ACOG says in terms of that pelvic exam is that that should be a shared decision between the patient and her provider. If she's asymptomatic and she's had a hysterectomy, she may not need a pelvic exam per se. Or if she has a cervix and is not due for pap screening and is asymptomatic, she may not need that pelvic. However, only by talking to her provider and the provider asking questions about her symptoms will they be able to determine whether that's needed. So we still recommend that women come in once a year for their annual, we can call it a GYN visit, and then determine whether an exam should be performed at that time.
Another question was, what recommendations for cervical cancer screening are there for women who have had a tubal ligation?
Yeah, the recommendations for screening with having had a tubal is exactly the same if you did not have a tubal. It doesn't have any change in cervical cancer rates or how we recommend screening.
Okay. And then we have one email that came through with a question. For women who have had a hysterectomy for reasons other than cervical cancer, is it necessary to have continued follow-up with the gynecologist?
That's a good question. It goes back to the previous question. Not all women have their ovaries taken out when they have a hysterectomy, and it also depends on what age the woman is. We still recommend that the women come in once yearly for their visits to address other concerns. You can have lower genital tract issues even after having had a hysterectomy that may need to be addressed with the gynecologist.
Okay. I don't think we have any further questions via email or by phone. So if there's no further questions from the audience, I think we'll continue with the management of abnormal pap smears.
Thank you.
This, as most of you know, this has changed numerous times. Thankfully, not a lot since 2012, and it can get pretty complicated. I'm sure most of you have either seen the ASCCP guidelines and go online to look at those, or have the app for that, which is a great tool. I'm not going to spend a lot of time on the algorithms themselves. We will look at them a little bit, and I'll mention a few things here and there. But what I am going to do is go into the meat of the article that those guidelines are based on and look at things that you might have missed had you just looked at an algorithm. So first of all, objectives. You should know how to manage abnormal pap smears in women 21 to 24 years of age. That's an extremely important part of this because we see a lot of people who forget that there is a difference in that age group, not only in their risk factors, but how we manage the abnormal pap smears. You should know the initial workup and subsequent management in women with atypical glandular cells. And then you should also know when it is appropriate to perform a pap smear after a woman has a hysterectomy, which we've discussed a little bit, but we're going to go into more detail with that. And also to know how to manage abnormal pap smears after a hysterectomy, should you do them either appropriately or inappropriately, actually. Again, I have no conflicts for this presentation. The information that I am going to discuss from here on out, for the most part, is going to be based on the ASCCP guidelines and the 2012 update consensus guidelines for the management of abnormal cervical cancer screening tests and cancer precursors. That article was published by Stuart Masad at Washington University in St. Louis, as well as other experts. And you'll see, most of you have already seen that, and we'll go through all of these algorithms, but again, I'm not going to spend a lot of time on each of these. Unsatisfactory cytology, basically you're either going to do colposcopy or you're going to do cytology in 2 to 4 months, depending on the situation. One of the things I want to point out here is that unsatisfactory results are usually from insufficient squamous cells. So because of that, you can't just rely on, well, let me just do an HPV test, and if that's negative, then I'm okay. In fact, the HPV testing cannot be relied upon in this situation because you really have insufficient amount of cells to test. So you really need to keep that in mind and stay with those guidelines. Cytology that is negative for intraepithelial lesion or malignancy but does not have either endocervical cells or transformation zone is absent or insufficient. You can look at the algorithm there. The biggest thing that you need to remember in this situation is that women who have insufficient or absent of endocervical cells or transformation zone are not at increased risk of CIN3 plus, so CIN3 or cancer. So that is why we really use a very conservative form of management on these folks. If you look at the management of women who are greater than or equal to 30, who are cytology negative, in other words, they have a normal pap smear, but a positive HPV, we get a lot of referrals at our colposcopy clinic for this situation. And many times these women do not need a colposcopy at that time. If you look at the algorithm, this is one of them I am going to do a little more detail on, is your options are either simply to repeat the pap smear in a year with an HPV test, so co-testing in a year, or doing HPV typing. So if you get 16 or 18 and they're positive for that, then you go to colposcopy. If they're not, then again you just repeat co-testing in a year. So there is no indication to go straight to colposcopy in this situation. If you have women who have an ascus pap smear, most of you are familiar with this algorithm as far as either, for most of us, we do an HPV test. If for some reason you don't have access to HPV testing, you can simply repeat this in a year. One of the things I want to point out, however, is if you have ascus and HPV negative pap, it is considered an abnormal pap. And therefore, if you have this in an older woman, it is not to be used as an exit for screening. So if this is your pap smear you get at 64, and you are expecting this woman not to have pap smears after that, this cannot be used as an exit pap smear. If you look at, this is another one where we get a lot of people referred for colposcopy when it's really not indicated. In the ages of 21 to 24, in either ascus or an LCIL pap. Basically, what they are recommending is that you really need 3 abnormals, including that initial one, if they are ascus or LCIL, before you really need to go to colposcopy. So if you have a lady who is 21, she has an ascus HPV positive pap smear, she does not need colposcopy at that time. You simply repeat cytology alone in a year. If she still has an abnormal, again, either ascus or LCIL, you still do not have to do colposcopy. You go and repeat it again. So for those of you who are a little older like I am, not like Dr. Kahn, you will remember back in the day where we used to do this, 3 abnormals before you actually had a colposcopy. Well, it's actually going back to that. And so if you keep that in mind with these 21 to 24-year-olds, that they do not need to go to colposcopy unless they have 3 abnormals in that low grade or ascus. Now, if they have anything higher than that, ASC-H, atypical glandular cells, or HSIL, then they go straight to colposcopy no matter what their age. The management of women with LCIL, and since we are not doing co-testing, when we didn't used to do co-testing on these, depends on obviously what their HPV status is. If they are LCIL with an HPV negative, then they really don't need to go to colposcopy at that time. It is really preferred that they go to co-testing in a year. And in postmenopausal women who have an LCIL pap, but no HPV test was done, then you really have some options. Either you can do an HPV test, you can repeat their cytology in 6 to 12 months, or you can go straight to colposcopy in those women if you like. If you look at the management of pregnant women with an L-sil Pap, it is preferred that they go to colposcopy. However, you can defer colposcopy until after delivery. And if you do that, you need to wait at least 6 weeks before you do the colposcopy, because all the inflammation and stuff from delivery can confuse things, both from the visual colposcopy and also from pathology. If those women do not have any evidence of CIN2 or 3 or cancer, obviously, then they can just go to postpartum follow-up if they have colposcopy during their pregnancy. For the management of atypical squamous cells but cannot exclude a high-grade lesion, those women obviously need to go straight to colposcopy. And for women 21 to 24 with either an ASK-H or a H-sil Pap, those women also need to go straight to colposcopy, even if they're 21 to 24. So if you have anything greater than an L-sil Pap, they should still go straight to colposcopy. Now, one of the things that we have done in a lot of women now who have an H-sil Pap is gone straight to treating those, because a high percentage of those women will end up getting treated anyhow. However, it is not appropriate to do that in 21 to 24-year-olds. So you should not go straight to LEAP on these women. These women definitely need to go to colposcopy. For women with H-sil, again, you have choices, and this is what I was talking about, either going straight to treatment with a LEAP or going to colposcopy first, and then depending on what your colposcopy showed, going from there. Atypical glandular cells, one of those things that we always hate to see because they can be very difficult to manage. So if we look, we'll take a little more time with this one. So for atypical endometrial cells, the recommendation is to do an ECC and an endometrial biopsy first to see if we get any pathology from that. If that is negative, then you need to go to colposcopy. Now, for all other categories of atypical glandular cells, you need to go to colposcopy and make sure you do an ECC. Now, depending on certain factors, they may also need an endometrial biopsy. And if they're over 35, then they need an endometrial biopsy as well. If they are less than 35 but have risk factors for endometrial cancer, obesity, long-term abnormal uterine bleeding, family history, those kinds of things, then they also may need an endometrial biopsy. Now, benign appearing endometrial cells or stromal cells or histiocytes. This is another one of those things that we kind of hate to see because it's abnormal basically, but what do we need to do with it? What's the risk factors here? So asymptomatic premenopausal women, in other words, premenopausal women who do not have abnormal uterine bleeding and do not have menorrhagia, they need no further workup. They can go straight to just routine screening. If you have a postmenopausal woman and they have these, again, benign appearing endometrial cells, stromal cells or histiocytes, they also need no further workup. Now, for postmenopausal women who have not, have not had hysterectomies and all of that, they need endometrial evaluation, either with ultrasound or endometrial biopsy. So subsequent management of women with atypical glandular cells, some of it depends on what their original pathology was, of course. So if you have atypical glandular cells that are not where they favor neoplasm or AIS, so just the routine atypical glandular cells, and you don't get any CIN or AIS or cancer, then they go to co-testing at 12 and 24 months. Now, one of the things we also see is people referring people for pap smears or doing pap smears in 6 months a lot of times. Most of the time, there are very few situations where that is indicated. There are a couple, and we'll talk about those, but basically they need co-testing at 12 and 24 months if they don't have any pathology. They have CIN2 but no glandular neoplasm, and of course you treat them as per the ASCCP guidelines. And then if you have an AGUS that favors neoplasm or AIS, even if you don't get anything on the pathology from your colposcopy, these people need a diagnostic excisional procedure, either cold knife cone or LEAP, because they are at much higher risk of cancer or a very high-grade precancerous type lesion. And this is one of the things that I want to certainly emphasize, that if you have that, then again, no matter what, even if you don't find any dysplasia, you don't find any cancer, you don't find any glandular problems, these people still need a diagnostic excisional procedure, and you should do an ECC after the diagnostic procedure. All right, so in this algorithm, you see we're talking about those women who have no dysplasia, no precancerous lesions, or possibly a CIN1 lesion after a lesser abnormality, in other words, ASCUS or LSIL. And that is pretty straightforward in their algorithm. One of the things I do want to point out to you, though, is that an ECC that shows CIN1 should not be treated as the traditional positive ECC. Dr. Kahn may not remember that, but we certainly do. And so the old jargon, when you had a positive ECC, we had to be very aggressive with that. We would do LEAPs, cold knife cones, and all that. And the reason that it is not, we don't do that anymore with CIN1 on an ECC is that in many studies it has been shown that the ECC gets contaminated from the ectocervical cells. So a positive ECC in this case may not necessarily come from the endocervix at all. So we don't want to jump to conclusions with this when we have a CIN1. Now, if CIN1 or no lesion is preceded by a lesser abnormality, again, either ASCUS or LSIL, and either the colposcopy is inadequate, the ECC contains either CIN2 plus or an ungraded CIN, or this person has been previously treated, then those people need to go for a diagnostic excisional procedure, either LEAP or cold knife cone. Now, this next one shows the algorithm for either no lesion or a CIN1 biopsy given a higher grade preceding pap smear, so ASK-H or HSIL. And for those people, you have choices of either co-testing, again, 12 and 24, not 6 months, a diagnostic excisional procedure, or you have the choice of talking to your pathologist and actually saying, hey, can you look at the pap smear, can you look at the biopsies, and see if they change their mind on any of those, which might then change your management. If an HSIL pap persists for 24 months, 2 years, without coming up with CIN2 plus, then you probably should do a diagnostic procedural procedure, LEAP or cold knife cone. The pap smear is telling you something's going on here, but you're unable to find it by your colposcopy. And as we found out in recent years, colposcopy is not as good as we thought it was. The other thing you need to make sure you do on these people is look in the vagina. Make sure that when you do your colposcopy, you're looking in the vagina for lesions as well. Now, management of women who are ages 21 to 24 who do not have a biopsy-proven precancerous lesion in this situation. So after again, we want to be very conservative with these women. If it's an ASCUS or LSIL, then we're simply going to repeat cytology. If it's an ASC-H or an HSIL, then you're going to manage as we had talked about before. Regardless of the antecedent cytology, treatment for CIN1 in these women who are aged 21 to 24 is not recommended. So no matter what they had, whether it's HSIL, whether it's ASCUS, if your biopsies are only showing CIN1 in these women who are 21 to 24, they should not be receiving a LEAP or a cold knife cone. Management of women with biopsy-confirmed CIN2 or 3. Basically, some of it depends on your colposcopy. Obviously, if you have an adequate colposcopy, you can either do an excisional procedure or you can do an ablative procedure. If it is inadequate, then you really should not be doing cryo or some other ablative procedure. Women who have unambiguous CIN3 carcinoma in situ have the immediate precursor to invasive cancer, and they should not be observed regardless of age or concern for their future fertility. Hysterectomy is unacceptable as a primary therapy for CIN2, 3, or 2-3. And for CIN2, CIN3, or CIN2-3, routine screening is recommended for at least 20 years, even if that extends past 65 years of age. So if they have this at 58, I'm sorry, but you got to still follow them for 20 years after that. So 78 would be your cutoff. If CIN2, 3, or 2-3 is identified at the margins of a diagnostic excisional procedure, or in an endocervical sample obtained immediately after a procedure, then hysterectomy is acceptable if the repeat diagnostic procedure is not feasible. Now, they don't really define what's not feasible. I'll leave that up to you guys. Basically, what they're saying is don't just willy-nilly do this, but if they don't have a cervix left or for whatever reason it's not feasible to do that, then you may do a hysterectomy. But that should not really be our initial or our really secondary plan unless we really need to. A repeat diagnostic excisional procedure or hysterectomy is acceptable for women with histologic diagnosis of recurrent or persistent CIN2, CIN3, or CIN23. All right, so let's talk about management of young women with CIN2, 3, or 2-3. In this case, you have choices. Yes, you can treat them, but you also can observe these women, and you can do that by colposcopy and cytology, and this is one of the places where you can do it every 6 months. And so what you do if you're going to follow these women is that every 6 months do a colposcopy and cytology, and you should probably be doing an ECC in these women also. And then this looks at the management of adenocarcinoma in situ. Obviously, this is something that we all hate to see because we know that there's a high percentage of these women who have cancer. So the recommendation is if you have this and then you really need to be doing a hysterectomy unless they are planning on becoming pregnant again. And then you can follow these women conservatively. If you follow them conservatively, then they will still need treatment or evaluation every 6 months. And the evaluation for this should be done with co-testing, with colposcopy, co-testing, and an ECC. So it's a little different than what we do with the rest of them. Also remember that colposcopic changes associated with AIS can be minimal, and that AIS frequently extends into the endocervical canal, and that AIS can be multifocal and discontinuous. One of the other recommendations that has changed is that in this situation you can use a CKC or a LEAP. In the old days, we were recommended that we should just do a CKC so we could see what the margins were. They do emphasize that the specimen should be intact, the margins should be interpretable, and avoid fragmentation, and that includes doing a top hat. So it's not really recommended to do that. So you can do LEAPs, and this was done because some people don't really have access to CKC or that kind of thing, and so this allows them to also treat people in this situation. All right, so this is where we come back to talking about the article that Dr. Kahn and some other people have just published. It's actually not out yet, but it will be shortly. And again, the recommendation is that asymptomatic women with a history of hysterectomy for a benign disease and no history of CIN2 require no further screening. All right, so if you have someone that has CIN1, LSIL, and you end up doing a hysterectomy for other reasons, those women do not need further screening. Only if they have CIN2 or worse do those women need screening. Now, this article, this is going to, and some of the other things that we're going to look at here is going to be a little different than what some of you are used to. It is probably going to be controversial to some people, even to some GYN oncologists. The people who did this article, besides Dr. Kahn, are also experts. Dr. Masad, who's again from WashU, Dr. Huff from UAB as well, Teresa Darrow from UC San Francisco, among other people. So these are the same people who have come out with the other recommendations for the cervical lesions, this is now going to be talking about what do we do with abnormal pap smears in the vagina. All right, so in women without a history of CIN2 or worse, who are inappropriately screened after hysterectomy, which we see a lot of those women in our colposcopy clinic, or who have CIN2 or worse and have completed their 20 years of surveillance, who have either ascus with a high-risk HPV positive, LSIL, or a normal cytology and are high-risk HPV positive, then it is recommended that you simply repeat co-testing in 1 year, or repeat cytology if co-testing is unavailable every year for 2 years. All right? And then, if the co-testing in 1 year or the cytology alone for 2 years is negative, then you can stop screening. Okay? Don't have to do anything else. All right? Alternatively, if they have ascus, LSIL, or HPV 16 or 18 positive, then vaginal colposcopy is recommended. Now, if you have persistent VAIN1 or LSIL for 2 years in women inappropriately screened, then you may extend their screening to every 2 to 3 years. In other words, if all you're getting back is an LSIL or VAIN1, which simply is evidence of HPV infection. It is not a true precancerous lesion, so it's simply saying this woman has HPV, and that's all we're seeing. Then you can extend the screening out to every 2 to 3 years. For women with a history of hysterectomy and either AGUS, ASK-H, or HSIL pap smears, so if you have any of those, then colposcopy is recommended. So if you don't have the low-grade stuff, you have something worse than that, then colposcopy is recommended at that time. All right, so follow-up after treatment for CIN2, including if they have a hysterectomy. So if they've got a hysterectomy and let's say they had CIN2 or 3, then co-testing at 12 and 24 months is recommended. So you do that at 12 months, do that at 24 months. If both of those are negative, then you can retest them in 3 years. If all of that is negative, then they can go to routine screening, which at this particular point in time is co-testing every 5 years for at least the 20-year period that they should be followed. If they have VAIN1, LSIL, or P16 negative VAIN2, you may defer colposcopy and simply repeat the co-testing in a year. So again, we're talking about people who have been treated for CIN2 or worse, and they're on their screening protocol. And so if they get any of these things, then you don't have to go to colposcopy the first time. You can wait till the second time. P16, for those of you not familiar with that, is evidence of a high-grade lesion. And so if it's P16 negative on a VAIN2, that helps you distinguish really between something that you really need to be worried about and something that is just HPV related. If VAIN1 LSIL is persistent in women post-treatment, then or for CIN2 or HSIL VAIN3 or P16 positive VAIN2, then repeat co-testing in 1 year. So if they have just, again, you've had this, they've been treated, and now on your follow-up they have just LSIL or VAIN1, then you can just repeat your co-testing in a year. If the cytology is greater than or equal to LSIL or they have a high-risk HPV at that time, then you need to go to colposcopy. Treatment is recommended for histologic proven HSIL VAIN3, P16 VAIN2. So if you do colposcopy, you do biopsies, and you see one of these things, then treatment is recommended. Again, all the charts that I looked at, all the algorithms were from the ASCCP guidelines, and then of course the other place that I got the information is from the article that will be coming out soon, and that is not going to be the last word, I'm sure, about vaginal pap smears, but it is, I think, an extremely important article because I get people all the time calling, discussing, all right, well, what do we do with vaginal pap smears? There are oncologists who think you shouldn't do any of it, and there are other people who think you should be doing pap smears every year on those people. So that particular article, I think, is an extremely important article to help get some organization to our screening in using that for vaginal pathology.
Thank you. Great. Thank you, Dr. Varner. We have about 25 minutes left. I'm going to give you a short talk on HPV vaccination and the current recommendations, and then we'll have the floor open for any questions. My disclosure is the same. So I'm going to discuss the current recommendations for vaccination, the benefits and the available vaccines, and we'll look again at the uptake of HPV vaccination in Alabama as compared with the United States. The HPV vaccine has the potential to protect against many different HPV-associated conditions, which include genital warts, cervical dysplasia and cancer, vaginal, vulvar, anal, and penile dysplasia and cancer. Also, may be on your handout, but not on the slide here. There's head and neck cancers that are associated with HPV, as well as a condition called recurrent respiratory papillomatosis caused by HPV 6 and 11. That is an HPV-associated condition. Oh, it's on the next slide. There we go. Before we talk more about the vaccine, I just want to remind everyone of the high HPV prevalence that I had discussed in the last talk. Remember, when people get infected with HPV, it's when they become sexually active in their late teens, early 20s. So in order to make this a primary preventive success, we need to vaccinate them before they get exposed to that pathogen. And so this plays into the recommendations, and it's very important to be thinking about vaccination in your teens prior to sexual intercourse. And again, looking at the cervical cancer incidence by ages, you can see that it's very low incidence at ages under 20, and so you really want to try and intervene before their risk goes up, before they get to the 20 to 54 age range and beyond, where the risk of cancer is higher. Same thing with deaths, very low proportion of deaths in the younger age group. So these are the 2014 recommendations from the CDC, and there's the Advisory Committee on Immunization Practices at CDC that puts out the recommendations for all vaccinations, and this was the report on HPV vaccination. So just briefly to go over what the HPV vaccine is made of. It's made of these non-infectious virus-like particles, also called VLPs, which are produced by one of the HPV proteins, L1, This is the major external protein of HPV, and each protein is type specific. So each HPV type 611, 16, 18 has its own L1 protein that produces a unique VLP. If you look at the picture of HPV, all of those pentamers on the outside are the L1 protein. These virus-like particles, or VLPs, are what's injected into the patient, and they elicit a humoral immune response. And that's where you get your neutralizing antibodies that protect people when they're subsequently exposed to HPV. The other part of the vaccine is what are these virus-like particles suspended in, and it's an aluminum adjuvant. So there's 3 different types of HPV vaccines available on the market today. The first one that was approved is known as Gardasil, or HPV-4, and this is a quadrivalent vaccine. It was approved for females and males by the Food and Drug Administration in 2006. So this was the first vaccine to be approved and released, and it contains type-specific